Hello everybody, my name is Wendy Jones and I am a pharmacist with a special interest in the safety of drugs in breast milk. I've been presenting at many conferences over the past 25 years on a variety of subjects, and I've decided as I work towards retirement that I'm going to record some of these and share them on my website so that they are of value to everybody else who I will no longer be seeing. So I hope this is of value to everybody. So today's topic is about treatment for anxiety and depression in breastfeeding mothers. This is a subject that makes up about 20% of calls to the Drugs in Breast Milk helpline and has been particularly high during lockdown because everybody is feeling very strange, very anxious about the future, feeling very restricted in what we can do, and it's caused lots of mental health issues. So the objective of this presentation is to look at the pharmacokinetics of the drugs, which I hope you will have already seen in the video that I've already made, and balancing the risks of the drug with the mental health of the mum, and trying to work out how we can support the mum who's having mental health problems and help her to continue breastfeeding if that's what she wants. But I'm also presenting some comments that mums wanted me to share with you about their feelings about treating anxiety and depression during breastfeeding. So mental health and breastfeeding are part of a big jigsaw. We can't treat either of them in isolation. Mental health has an impact on breastfeeding. Breastfeeding problems can have an impact on mental health, or they can also have a positive effect on mental health by feeling something that the mum feels very positive. And underpinning both of these are attitudes to sleep and whether the amount that her baby is sleeping meets her expectations of what life with a newborn baby would be like, and how other people are reacting to within this massive jigsaw as well. So all of these parts come together to produce a greater picture. We can't think of any of them in isolation, which why it's so wonderful that there are projects beginning all over the country about helping mental health practitioners to understand more about breastfeeding, and breastfeeding advocates understanding more about mental health, and each pair signposting to each other. So antidepressants are often begun in pregnancy because actually depression is highest in pregnancy because our norm has changed. We have a new norm without the routine of being in an office or a workplace with specialists at special times. But often these mums are managed in primary care by doctors without specialist knowledge. And I have found over the last 25 years that women are often told to stop their medication as soon as they become pregnant, or they decide to do so because we think back to thalidomide and the risks of damaging our very, very precious babies. And often also mums are scared because they've taken them for a couple of weeks before they've realised that they're pregnant. And we know that a large number of pregnancies happen accidentally. So if they stop their drugs in pregnancy, their mental health tends to decline even further. The NHS say, as a precaution, antidepressants are not usually recommended for most pregnant women, especially during the early stages, because they may be dangerous for your baby. But exceptions can be made if the risks posed by depression outweigh any potential risks of treatment. And we've already changed that balance of risks and benefits by saying they may be dangerous for your baby. And I suspect that most women will only read those few words. But actually, most drugs have very little effect above the basic rate of abnormalities that are subject to in every pregnancy. And if we're asking women to go along and discuss pros and cons with their doctor, it may be that we have the blind leading the blind. We need specialist sources. And one of those is Mother Risk in Canada, who did a lot of work about presence during pregnancy, and also about how the way we tell a mum that a drug may be dangerous affects how she perceives it. So if you say to her, your baby has a 5% chance of being born abnormal if you take the drug, that's very different to being told you have a 95% chance of your baby being absolutely fine. It's very similar to fat-free. If you're told something has 5% fat, it sounds very different to it's 95% fat-free. Fear of teratogenicity often prompts women with very severe mental illnesses to stop their drugs quickly. And we have a huge morbidity in both mother and children if we have untreated depression, bipolar illness late in pregnancy. And suicide in young women is still the greatest cause of death. If they have mental illnesses. There actually are no clear teratogenic patterns across many, many studies. So we need people to have this information before they ever think about becoming pregnant or becoming pregnant by accident. This should be part of our routine care of women. It may be a leaflet that they're not going to look at for 5 years. They will remember that they were given this information. So I'm not going to stop now and talk about how drugs pass into breast milk, but I'm going to use the terms that I introduced in this video, how do drugs get into breast milk? So I would encourage you to have watched that before we go any further. There are a number of expert specialist texts which provide the information that we need, the pharmacokinetic data. Hale's Medications and Mother's Milk is the expert book across the world because it covers just about everything. We can also look at LactMed, which is freely available online. And the two books that I've written, Breastfeeding and Medication and Guide, my co-edited Guide to Supporting Breastfeeding for the Medical Profession, rely on these sources, but I've tried to interpret them in a way that makes them easier to understand for mothers and for busy professionals. So if we look at the two most commonly prescribed antidepressants, sertraline and citalopram, sertraline has a milk plasma ratio of 0.89, well below the 10%, which is safe in breastfeeding. Its half-life is round about the 26 hours, and it is highly plasma protein bound, which is reflected in its low relative infant dose. So because the levels are very low, the amounts ingested by the babies are very small, and it's not usually detected in the serum of the infant. So that's what makes it the most widely used drug by breastfeeding mothers. Virtually none of the drug gets into breast milk. But the same is also true of citalopram. And while its pharmacokinetic data is slightly different, its relative infant dose is still very, very low, well below the threshold of 10% where we would say that there is any risk. And although the milk plasma ratio just tips above 1, it would suggest that it's concentrating in milk, but actually mainly babies are exposed to it, do absolutely fine, even though we can detect some in their bloodstream. The only adverse event that's been reported has been a baby exposed to 40 milligrams of citalopram who had an uneasy sleep pattern, and this resolved when the mum's drug was reduced. So either of these drugs can be given to a breastfeeding mother and she can continue to breastfeed as normal. She doesn't need to time her feeds. She doesn't need to do anything different at all. Ideally, take them in the morning and just carry on with life as she would do at any other time. The ones that are not first choice for me are paroxetine and fluoxetine. Now, very little paroxetine gets into breast milk, reflected by this very low relative infant dose, but it's a drug that is very difficult to come off of, and it causes discontinuation syndrome for the mums. So they may struggle long term to get off it again. And that is the sole reason why I wouldn't put it in a first choice drug. Fluoxetine has a longer half-life of 2 to 3 days, and we know that more of it gets into breast milk than with the other 3 drugs. Adverse effects such as colic, fussiness and drowsiness have been reported in some babies, but we can't do a randomized control trial because that baby might have been colicky, fussy or drowsy as part of its normal wake up. One study showed decreased infant weight gain, but it hasn't been replicated in other studies. So if this is a drug that the mum has had in the past and which works for her, and ideally the baby is more than 6 weeks of age so that its renal and hepatic function is fully developed, there is no reason that she can't have it. It's just that we wouldn't initiate it as first choice without trying one of the other drugs first. If you suggest to a mum that she has a drug and then has to pump and dump, we have to think carefully about the way she's going to manage her milk supply. Some mums are told to pump and dump for the first 4 hours after they've taken a drug and throw that milk away. Actually, it makes no sense at all, because after 5 half-lives, the drug has reached a steady state. And otherwise, moods could come and go throughout the 24 hours as the level in the bloodstream kept down. And to suggest that she's dumping this milk make it sound as if it's just rubbish and it doesn't have any value. And breast milk is the most wonderfully valuable substance that human body is able to produce. If we're looking at anxiety in breastfeeding, the first port of call would normally be the SSRIs, which are also antidepressants but have anti-anxiety activity as well. But actually, we also want to normalise anxiety as part of being a new parent. We all worry about whether we're doing everything as well as everybody else. We kind of set ourselves up to be perfect, and perfect doesn't exist. But what needs to happen more than anybody else is somebody to listen to how she feels with empathy and without giving her advice, just letting her say how she feels at the moment, and to express that anxiety and sit alongside it, not necessarily challenging it, but accepting that's how she's feeling at that time. The drugs that wouldn't be first choice are the benzodiazepines, particularly diazepam, which has a very long half-life, around 72 hours. So if a mum takes it regularly, it will accumulate in the baby's bloodstream. If it has to be prescribed, then lorazepam is a safer drug. But actually, these drugs, if used for panic attacks, take at least 20 to 30 minutes to be absorbed from the body and start to work. And a panic attack would actually have diminished before the drug had got into the body. So it actually isn't helping, other than if you're using it as a preventative. Lots of people ask for herbal supplements, and we rarely have any data. There are lots of products that are marketed as helping anxiety. There are very few of them that I could, hand on heart, say are safe. In the worst situation, I have lots of calls where mums are awake in the middle of the night, unable to get back to sleep, and they get prescribed sleeping tablets. Sleeping tablets will pass the blood-brain barrier and may sedate the baby if she continues to feed overnight. If she doesn't feed overnight, then she risks developing mastitis because the milk isn't being removed from her breasts, or it will lower her milk supply because prolactin levels are highest overnight. So sleeping tablets really need to be the last resort. But there are times when a woman's mental state is so poor that she needs to sleep in order to just have a chance of recovering. And it's very easy to say, stop breastfeeding then, and for the rest of the family to then hear that breastfeeding isn't as good for the mother as had been thought, and suggest that they will carry on bottle feeding the baby so that mum can get more rest. Breastfeeding is a very unique relationship between mother and baby, and there is an exchange of hormones, particularly the release of oxytocin, which is a very calming drug. And removing that can also make mental health worse. So we need to think very what we're suggesting and how we're talking about it. Is it possible that somebody else can look after the baby overnight, bring it to the mum to feed, and she kind of feeds in a drowsy state, but then the carer looks after the baby, makes sure mum isn't asleep with the baby, and takes it away and looks after it, changes nappy, whatever else needs to be done, so that the breasts are still empty of milk, the oxytocin still happens, the milk supply still happens, but the mum can enjoy the oxytocin and as much of an undisturbed night's sleep as is possible. But every situation is different. When we're looking at antipsychotics in breastfeeding, I always think of the lady in Bristol who jumped off the cliff with her baby because she had decided to stop her antipsychotic drug in order to breastfeed. And I think this is one of the cases where we really need to talk to the mum beforehand and discuss all of the data in a way that she can access about risks and benefits. So quetiapine has a very, very low infant dose, and up to 400 milligrams a day produce very low levels in breast milk. So it's a drug that she can breastfeed on. Olanzapine still has very low levels, although the half-life is much longer. Again, research shows it produces low levels and undetectable levels in the serum of breastfeeding infants. But we need to make sure that these babies are safe overnight, particularly if the mum is drowsy. And we need to think not just about whether the baby is in bed with the mum, but if the mum gets up to feed and falls asleep on the sofa or in a chair, which is a greater risk of sudden infant death. The not so good options in breastfeeding are lithium, because although in theory, if the baby is born full term, it can be exposed to lithium through breast milk, it would need to have its blood monitored in exactly the same way as mum does. And very few medical teams will agree to do this. Aripiprazole passes into milk in very low levels, but so far with the many mums that I've come into contact, not one has been able to achieve a full milk supply because aripiprazole seems to lower serum prolactin. So they will at best be mixed feeding. And that's absolutely fine if that works, but the mum needs to be aware of that in advance so she doesn't have her expectations raised too high. Intention to breastfeed and depression is really important. So as the lowest risk of postpartum depression was found amongst women who had planned to breastfeed and had succeeded, whatever succeed meant in their decision making. So they reached their goal. But the highest risk was among women who had planned to breastfeed and hadn't gone on to do so for as long as they wanted, as exclusively as possible, or hadn't been able to debrief how they felt. And this is where mental health and breastfeeding support go hand in hand. So if we have this mum working with a mental health worker and she perceives that something is going on, breastfeeding isn't as easy, then she can refer to somebody to help with the breastfeeding. These two are then going hand in hand. We're often told that breastfeeding causes depression, It's the pressure of being told that breast is best that causes women to struggle. But actually, when I asked the women on my Facebook page, they told me it was the pressure to stop in order to take medication that made them feel worse. They said what they wanted was to be listened to and to be signposted to breastfeeding support. And for some of us, it matters how we fed our old children, and have we ever been able to debrief our own experiences? If you had a positive breastfeeding experience, feeding your own children, then you're more likely to promote it. If you chose not to or didn't succeed to your goals, you will react in a very different way. Breastfeeding is actually just a health promotion issue, the same as any other one. Sleep deprivation can affect the whole family. And one of the immediate reactions that all dads and grandmas and wider families say is, if you want some sleep, let me give the baby a bottle overnight. I can't help you if you won't let me feed. And this creates a whole battle again, because the mum's not feeling listened to. Maybe she needs somebody to tuck her up in bed for the afternoon, and bring her, or even longer, let her have some rest and relaxation, produce a nest for her and bring her food and drink. I'd love to be able to have a hotel that had a breastfeeding mum with everything on tap that she needed, whether it was chocolate, cake, cups of tea, cups of coffee, a cuddle, a massage. I think we would have much happier mums. So it's about the wider family, and it's about society as well. And I can only promote the Basis website, which has some invaluable information about sleep and expectations of sleep, and how mothers who are breastfeeding actually have better quality of sleep and more sleep than formula-fed babies, which goes against what we might assume. I'd also advocate any prescribers looking at the perinatal mental health toolkit, which has so many different links and pieces of information. It's written by GPs for GPs, and I can't praise it enough. The pain of breastfeeding can also cause depression, because women can be very disturbed by the fact that they thought breastfeeding could be straightforward, and if it wasn't, that they then failed. And failure is what is in their heads, not necessarily what everybody else thinks. And mothers who stop breastfeeding due to physical pain or difficulties are at greater risk. So this paper goes back to the other one as well, about expectations and the need for support. Having antenatal mental health difficulties can lead to postpartum symptoms, and also it can have effect on stopping earlier than they want to. But in a crazy way, there is an inverse association between the number of times a mum breastfeeds and her anxiety. And I feel strongly that this is about oxytocin being produced during breastfeeding, and about skin to skin. The longer you spend in skin to skin with your baby, the more you are interacting and setting yourselves to be in line with each other. Breastfeeding is about more than just milk transfer. It's a whole different emotion, and not something that we can just capture in an easy way. Breastfeeding does mean everything to some. One mum told me it was like a deep grief. I wanted to die if I can't breastfeed any longer, Mum. My doctor doesn't understand. Whilst not everybody is so worried. So she'd been prescribed sertraline. She'd been told about how little got into breast milk, but she thought, actually, I'm okay to stop now. I'd rather take the drug. My concern is long term, and nobody's actually studied that. But I'm good with the decision that I've made. Mental health can conflict with breastfeeding if mothers are told to take time for themselves and private or retire breastfeeding, told to stop breastfeeding to take medication, or feeling judgmental attitudes to breastfeeding. Are you still feeding? Are you feeding again? And this concept that mothers are drained by breastfeeding. And often this ignores the core beliefs that they may have about breastfeeding and may lead to arguments. There are some guidelines that I found. They're in 2016 for a while now. Lack of sleep is a common precipitating factor to depression. Mixed feeding should be supported if this is the best way to protect the mother's well-being. So again, we're not allowing the mum to decide. We're saying it probably would be a good idea. Maybe your partner can feed overnight. Using a pacifier for nutritive sucking can be a benefit, but it actually also takes time from stimulating the breast. And the more the baby is at the breast, the more milk is supplied. And we've got this mention of cot death. Now, if you've got a mum who is already anxious, the words cot death are going to increase her anxiety 1,000,000 times. The same guidelines say breastfeeding can have an effect on sleep and daily routine that's detrimental to the mother. Well, actually, having a baby has a complete effect on your daily routine. We can't really ask babies to fit into our routines because they have different needs. They have tiny tummies. They need to be fed regularly. Life is never going to be the same again once you've had a baby. And all of these, there is just a hint of negativity all the way through them. Comments that were reported to me that a doctor said, my doctor said there's a risk of neurological damage to my son due to the accumulation of citalopram. Then she went on and said, but I really want to breastfeed. So he backtracked, said it was a small risk and the benefits outweigh the risk, but it is a risk nonetheless. But all she's hearing is that first bit of there is a risk. And her anxiety centered around her children's health, and she was worried. It's very difficult to go back and unhear something that's caused you anxiety. In the middle of the night, those words are going to be. I was contacted by one mum who was in crisis, and she recognised that she was in a very bad place. So she went to the surgery. The mental health team had just told her to go to her GP. GP didn't know what to do. She'd been there since 8 a.m. It was then 1 p.m. She hadn't been offered any food, and she was alone. Nobody was sitting with her. Nobody had even brought her a drink. So she was messaging me on her phone, and I suggested some drugs, and they prescribed them and sent her home to be reviewed the following morning. Kind of really wasn't enough. She needed to be mothered. She needed to be looked after and made sure that she was in a safe place. That I don't know whether she had anybody at home with her, and whether she was still in a safe place, being sent home like that. This is where women can fall down the cracks. Barriers to accessing support is often around, they will take away my children because I'm not a good mum, I'm not coping. So it's very difficult to work out who they will be. It seems to be around social services and not understanding that actually people are out there to help them cope. Recognise or deny their symptoms, or their partners will do so. I remember one dad saying to me, no wife of mine needs to be depressed. I provide everything she could possibly need. But maybe they're not ready to access support. Maybe they're not having enough time to think or know what actually is available to them. So we need to be proactive. Some mums aren't honest about how they feel because they don't think anybody can help them, or they haven't admitted to themselves, or they're just too embarrassed to say, I'm not coping. This back to, I need to be perfect. I can make it work. I just try harder and it'll all be okay. The mums wanted me to say that they wanted everybody to be considerative and supportive. Excuse my dog who wants to join in as well. Visit to the doctor, he told her that feeling depressed was normal because she had 2 children under the age of 3. And if you don't feel like it every day, there's nothing to worry about. You're left feeling terrible and even disempowered. And just telling a woman who is exhausted or despairing, just give a bottle, it'll make it better. It doesn't, not at all. Never signpost a mother who says she thinks she may have postnatal depression to contact her health visitor herself. It might have taken a lot of courage to voice her fears in the first place, and to try and start again or to leave a voicemail is really hard. And I think this last comment is really incisive. Formula is not a white knight on a fiery steed that can charge in and fix any or all of the challenges parents face in the early days. Being a mum can be very tough. Most importantly, they wanted to say, listen to us and don't just tell us. If we're struggling to breastfeed, signpost us to good breastfeeding support, and don't assume a roundabout way of saying we want to stop breastfeeding. Stopping breastfeeding can make us worse, regardless of the age of the baby. Listen and respect us. So, in summary, I want you to take away that we need to provide evidence-based information and shared decision-making for the mum and their partner, or whoever else she chooses to bring with her for support. Let's promote and support breastfeeding wherever possible if that's what the mum has chosen. Let's not use it as a rod to beat somebody. It's her choice, it's her child. But support her to feed as normal if that's what she wants. Healthcare professionals need training on breastfeeding and about the safety of drugs in breast milk. But above all, we need a sensitivity to the needs of mothers about infant feeding. If a mum is having mental health issues, she needs to be listened to and supported rather than told what she needs to do for her baby. I hope this presentation has been useful and that you will be able to go away and use it in your practice. I'm very happy to take any emails that you want to send me on any different drug or situation that comes up. But thank you for listening and take care.